Hello, everyone. Welcome to Doc Talks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports Golden Town. Today, we have with us Dr. Kanwal Raghav from MD Anderson, and he's going to tell us about his poster that was presented at ASCO GI25. Welcome, Dr. Raghav.
Thank you, Manju. So I'm very excited to present some of this data. And one of the reasons for presenting this data is this is the drug amivantamab is sort of like the new kid on the block with two large first-line and second-line colorectal cancer studies, which are currently ongoing, OrigAMI-2 and OrigAMI-3. These are global studies and are looking at the efficacy of this drug and its safety in first and second line against standard of care. So hoping to accrue patients on it and seeing if we can move the field in the right direction. But this is OrigAMI-1. This was the first study of amivantamab with or without chemotherapy in patients with colorectal cancer. There were multiple cohorts in the study. We are concentrating here on the right-sided metastatic colorectal cancer. So anti-EGFR antibodies, cetuximab and panitumumab are currently the mainstay of treatment for RAS, BRAF, HER2 negative wild-type patients. Which generally tend to be more efficacious in the left-sided population than the right-sided population, although some data is showing up that with hyperselection, even within right-sided population, there could be efficacy. There are unfortunately many resistance mechanisms to anti-EGFR therapies, MET being one of them. However, no MET inhibitors are routinely used in treatment of metastatic colorectal cancer, despite the fact that MET expression is ubiquitous in colorectal cancer. It is associated with poor prognosis and can lead to resistance to anti-EGFR therapies. Amivantamab is a bispecific EGFR MET antibody, which also has immune cell directing activity. It is currently approved in non-small cell lung cancer. It has also shown promising activity in RAS, BRAF wild type left-sided colon cancer in the OrigAMI-1 study, the results of which were presented last year. Here we are going to present the updated data for activity of amivantamab as a monotherapy and in combination with chemotherapy in right-sided population, knowing that there is a differential effect of anti-EGFR drugs in right and left-sided population. So this was a global multi-center study. The analysis here assessed the efficacy and safety of amivantamab monotherapy in right-sided patients who had had second or third prior line. Prior anti-EGFR therapy was allowed in these patients. And then in a second line setting after first prior line, it was used in combination with chemotherapy and no prior anti-EGFR was allowed for that cohort. So this is cohort C, cohort D, and E respectively. So you can see this is the overall design of the study. The study had left-sided population, two cohorts, cohort A and B. We are going to concentrate on cohort C. And then cohort D and E allowed right and left-sided disease, but we are going to specifically look at patients with right-sided disease. So you can see there were 23 patients in cohort C and about 7 total patients in combination with chemotherapy in cohort D and E. This is a very standard makeup for a population of this type. You can see that about 43% of patients had had prior anti-EGFR therapy in cohort C. And the primary tumor locations were spread across cecum, ascending colon, hepatic flexure, and transverse colon. Many of these patients were heavily pretreated with up to 3 lines of therapy in the monotherapy cohort. So this is a safety analysis. No new safety signals were identified during the study over and above what we know about amivantamab. As you can imagine, the anti-EGFR activity does lead to typical side effects like acneiform rash. A majority of these were grade 1 and grade 2, with only about 4% being grade 3 or higher. And then there are some side effects such as hypoalbuminemia and peripheral edema that are associated with the MET inhibition. And you can see again, majority of those were grade 1 and 2, with 13% being grade 3 or higher. And then there are some infusion-related reactions that you can see, and some ALT, AST elevation, but most of these side effects are still mostly grade 1 and grade 2, and with few being grade 3. So this is the efficacy endpoints. You can see that in this highly treatment refractory population, about 43% of those which had already had an anti-EGFR exposure, the objective response rate was 22% with a single agent, and about 43% in a second line setting in combination with both FOLFOX and FOLFIRI. The key here is that the duration of responses were long, about 9.8 months in the monotherapy cohort, and it was not evaluable in the combination cohort, with range being from 5.8 months onward. There was also about 80% disease control rate, and the median PFS was about 3.7 and 7.4 months, respectively. This is a waterfall plot, and you can see that there was one CR, about four partial responses in patients that were right-sided. And then again, in the chemotherapy cohort, there were three partial responses. The lower table also shows some of the molecular makeup of these tumors. And as you can see, this occurred across patients who had TP53 APC mutations. So there was evidence of activity across a wide range of mutations, including some of those that confer resistance to anti-EGFR, such as PIK3CA, because you can see this patient with the confirmed response actually did have PIK3CA mutation. This is a spider plot showing duration of responses. You can see once those responses occur, many of those responses are long lasting. I think this is a key for this, where the median follow-up was about 8.1 months for the monotherapy cohort and about 8.2 months for the combination cohort. And then, in conclusion, we do feel that amivantamab as monotherapy or in combination with chemotherapy provided promising anti-tumor activity with objective response of about 22% in monotherapy cohort and about 43% in the combination cohort. The safety profile was very acceptable, with no new safety signals. It showed activity in right-sided tumors across a variety of mutations. And then the OrigAMI-2 and OrigAMI-3 are currently ongoing. So I think, this was a key study, and I'd like to, of course, thank the patients and their caregivers and the study staff that made this study successful. We are hoping to see this activity and possibly the next analysis for OrigAMI-2 and OrigAMI-3.
Okay, thank you very much, Dr. Raghav. So you mentioned that the left-sided ones, results were available last year, right? Is there a lot of difference between the left-sided tumors and the right-sided tumors in terms of the response?
Yeah, so when you look at anti-EGFR therapy per se, Manju, there is a definite difference between left-sided and right-sided tumors. Even prognostically, right-sided tumors tend to do worse than left-sided tumors. But if you look at the analysis of 80405 or some of the other studies, it's quite clear that there are, mechanisms beyond just the classic mechanisms like KRAS, NRAS, BRAF, and HER2 wherein right-sided patients do worse than left-sided patients with anti-EGFR therapy, even when adjusted for these factors.
Okay. Okay. And then these the origami 2 and 3 are enrolling right now, right?
That's right.
Do
Both
you
these
have
studies are
information
open.
about where these trials are open? Are they open at MD Anderson too?
So they are open at MD Anderson, but they're also open across multiple sites in the US.
Okay.
And these are two randomized trials. So the Origami 2 study is a first-line study. It's only
Mhm.
for left-sided patients who are
Okay.
RAS BRAF wild type. And the
Okay.
randomization is to amivantamab plus chemotherapy of choice from the
Okay.
provider and
Mhm.
anti-EGFR plus chemotherapy of choice, so FOLFOX or FOLFIRI.
Okay.
And the Origami 3 is a second line study. So these are
Mhm.
patients who have already received bevacizumab plus chemotherapy in a first line setting. And then these patients subsequently would be getting amivantamab plus chemo and versus cetuximab or bevacizumab uh, versus plus chemo. And the
Okay.
second line study allows both right as well as left sided patients.
Okay. Okay. So basically what you're saying is that for the first line trial, those would be patients, you know, if they get on the experimental arm, they would not receive Setux. Because I'm just asking it this way because people are more worried about getting Setux because of the skin reactions, right? Like, so a lot of people like to get like Bev first line and then,
That's right.
yeah.
It is true that that side effect profile is concerning, but Manju, it is also very clear from the data that left-sided patients do derive survival benefit when they
Mhm.
are exposed to anti-EGFR over bevacizumab in first-line settings. So I think,
Okay.
the trial has been designed with the current standard of care in mind. But there is a possibility that patients who do not want to have Bev it's anti-EGFR in first-line setting. For them, their Origami 3 is an option, which would be, anti-EGFR versus amivantamab in a second-line setting.
Yeah, yeah, yeah. So that's what I was trying to
Yes,
ask really is that if people did not mind getting EGFR in first line, being on this trial, there is like a 50% chance to be
that's right.
randomized to the arm to get Setux. But if they really didn't want, because I think if they get on amivantamab, then probably they won't be, it will be fine for them, right? Because it's not the same as Setux, right?
That's right.
Though the rash is kind of similar, maybe
The
not,
rash is similar. Yes. Yeah.
yeah. So, and
But
then
you're
in the
right. Like
second,
if you're
yeah,
taking patient preference into view, then those that cannot get on Origami 2 can definitely get on Origami 3,
yes, yes, yeah,
right?
that's where I was going. Okay, so that's really helpful. And then, do you have any idea of the number of slots? Because so for I was under the impression that they have not started enrolling, so that's not true. They have actually both 2 and 3 have started enrolling.
Yeah, so we are activated here at MD Anderson, and we do have there's no specific slots for any particular site, but the
Okay,
Origami 1 study
altogether.
is a 1,000 patient study. Sorry,
Okay,
two Origami 2 is a 1,000 patient study, and Origami 3 is about 700 patient study.
okay, okay.
Yeah,
So it's just that like when they know that they're all wild type, this would be something a
that's
first
right.
line trial too. Yeah.
Before you
Okay.
begin any treatment, and I think with the recent data with Breakwater, add to it the data from Keynote and Checkmate, I think we've created enough uh, evidence to suggest that no patient with metastatic disease should begin any chemotherapy, prior to getting their molecular profiling, right? So I
Mhm.
think everyone should focus as soon as they're diagnosed, they should focus on like figuring out their molecular subtype, because then they can either be a part of clinical trials with more targeted therapies, or definitely if they're BRAF or MSI, they can go to current first line standard of care, which would be IO and BRAF therapy.
Yeah, okay, okay, that's a great point. Because I think that right now, for even there's Mountaineer for HER2, and then like there's a G12C
Yeah,
trial too,
they're all
right?
coming
So there
towards
are,
the first line, right?
yes.
And it's
So,
quite clear from the current data that as you bring these drugs up in the first line, you are increasing the relative benefit of these drugs.
okay, okay. That's important to know. And then as for a side effect, so I think that this data would be most useful when people are considering the second line, the origami 2 and 3, and they might be concerned about the side effect profile. So basically what I heard you say is that most of them were grade 1, maybe there were some grade 2 and grade 3, right?
No,
And
most of them are grade 1 and grade 2,
grade 2, okay.
but very few of them, like as you can see in the monotherapy cohort, at least here, about 4 to 5% were grade 3 with
Okay,
regards to the rash.
okay.
Right now, there are some side effects of like hypoalbuminemia and peripheral edema.
Mm-hmm.
That can also be more, but again, these are manageable with dose reductions and dose modifications, and the rash can be very well controlled with proactive medication, proactive management and prevention of acneiform rash.
Okay. And the same thing, like getting doxycycline,
That's right.
is that the same kind of thing?
Oral antibiotics, topical antibiotics, steroids when needed.
Okay.
Um, yeah.
Okay. Okay. So the other question was like the monotherapy arm. So that is not um, kind of relevant anymore, right? Because now the ongoing trials are with the phase 3 trials are with combination with chemotherapy,
That's
right?
right. Yeah.
Yeah. And the dose like between so, I mean, I'm asking these questions because, like, if somebody wanted to know, like, if there's a discussion and they want to know, like, how does it compare with Setux? Like, what would you say? Is it kind of half the, like a
Yeah,
really ballpark? Yeah.
yeah, I don't know. That's that's where the trial comes into the picture,
Okay.
Manju. I think the motivation for anyone to participate on that trial should be because we feel that there could be higher efficacy, right?
Hmm. Hmm.
I don't know about the safety signal as yet, how it would compare.
Hmm.
Um, but yeah, I mean, I think in the clinics, the rash is very much like an anti-GFR rash, but what would be the proportion or what would be the percentage of patients getting that rash or the severity? That
Hmm.
remains to be seen.
Okay. 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 This is very helpful. I think that's it. Do you have anything specific that you want to convey that we
No,
have not
just
talked about?
just the emphasis on getting molecular profiling as soon as possible, and then trying to participate. I mean, these are big trials, and they need patient participations to make them. I wouldn't say. I would say to answer the scientific
Hmm.
question in a relevant fashion, we do need patient participation, and there is enough data that there is a clinical equipoise that there is good activity of these drugs.
Okay. And because they are phase 3, you get standard of care anyways, right? If
Oh
you get
yeah,
on the
yeah,
experimental
yeah.
arm.
You
So
will
that
definitely
we both,
get standard of care. So there is no way you're getting anything that's less effective, even if you get on control arm.
okay. Okay. Thank you so much. This was very helpful.
All right. Thank you, Manju. Appreciate it. Thank you,
Yeah.
Isabella. Take care. Bye.
Bye.